Stroke is the leading cause of death and adult disability worldwide. Stroke is a clinical diagnosis and is defined by the World Health Organization as a clinical syndrome consisting of rapidly developing clinical signs of focal and at times global disturbance of cerebral function lasting more than 24 hours or leading to death with no other apparent cause other than that of vascular origin. It is a medical emergency for which there are effective strategies to help reduce neurological disabilities and mortality. Management of acute stroke can be divided into acute phase and chronic management phase. Ischemic stroke accounts for 80 to 85% of all strokes. The acute management of ischemic stroke will be presented here. At the end of the presentation, you should be able to understand the importance of stabilizing the patient and to promptly treat reversible medical conditions to reduce neurological damage. You should also be aware of the initial evaluation of the patient presenting with acute focal neurological symptoms in order to exclude stroke mimics and confirm ischemic stroke. Next, you should be familiar with the various treatment options in patients with acute stroke. The early goals in the acute stroke management are, first, to stabilize the patient following the basic principles of resuscitation by ensuring a patent airway, checking that the patient is breathing spontaneously, and making sure that the hemodynamic status is not compromised. Second, to confirm that the neurological symptoms are likely due to a vascular process as well as exclude potential stroke mimics. Third, to manage the patient in a stroke unit where patients can be monitored and cared for by trained personnel. Treatment options in the acute setting include reperfusion therapy with thrombolytics or antiplatelets. These will be elaborated further. Protection of the airway and maintenance of oxygenation is of paramount importance. Airway integrity needs to be established and monitored if the patient has depressed consciousness or evidence of brainstem dysfunction. Oxygen should be given if patient is hypoxic. The patient's blood pressure should also be checked. Hypertension in the acute phase need not be treated unless there are specific indications such as hypertensive encephalopathy, renal or myocardial compromise, and if the patient is being prepared for thrombolytic treatment. If the patient is hypotensive, fluid resuscitation has to be instituted as hypoperfusion will exacerbate the neurological disability by further damaging the ischemic penumbra. The ischemic penumbra is a rim of mild to moderately ischemic tissue lying between normally perfused tissue and infarcted tissue, and this area may remain viable for several hours if appropriate treatment is given. The concept of the ischemic penumbra is illustrated in an example on the right on the effects of hyperglycemia on the penumbral tissue. Examples of other conditions that may exacerbate brain damage and needs to be promptly treated are hypoglycemia, seizure, and fever. After initial stabilization of the patient, a history and physical examination should be performed. It may not always be possible to obtain the history from stroke patients, and hence, such history needs to be obtained from eyewitnesses. The aims are to determine if the presentation is consistent with a vascular etiology, to localize the cerebral structures likely to be affected, and to exclude other stroke mimics such as TOTS paralysis, hemiplegic migraine, etc. An urgent brain CT or MRI brain should be performed to exclude intracranial hemorrhage. Brain imaging may also reveal other brain pathology such as tumor mimicking stroke. Laboratory investigations are important to rule out toxic metabolic causes as well as anemia, which may exacerbate the patient's condition. Cardiac investigations such as ECG is important for diagnosis of concomitant myocardial infarction and rhythm disorders such as atrial fibrillation. Patients with acute stroke are best managed in the acute stroke unit, which is a geographical area for the multidisciplinary care of these patients. This allows close monitoring of neurological and medical parameters. It is staffed by a team of healthcare professionals specialized in the care of stroke patients. Care in a stroke unit has been shown to reduce mortality, improve neurological and functional outcome, decrease stroke-related complications, as well as reduce hospital readmissions. The concept of reperfusion therapy is arterial recanalization to salvage ischemic tissue, thus limiting tissue damage, therefore improving neurological and functional outcome. Intravenous thrombolysis with recombinant tissue plasminogen activator, or RTPA, has been shown in clinical trials to be efficacious if administered to appropriate patients within 4.5 hours from onset of symptoms. Patients treated with IV TPA are more likely to be functionally independent after 3 months. Intra-arterial thrombolysis involves direct instillation of the lytic agent to the clot and has been shown to improve clinical outcome. However, intra-arterial thrombolysis for acute stroke has not received regulatory approval and should not preclude treatment with intravenous RTPA in otherwise eligible patients. Current guidelines suggest that intra-arterial thrombolysis is reasonable in patients who have contraindications to intravenous thrombolysis, such as those with recent surgery. Endovascular techniques such as mechanical thrombectomy and clot aspiration in stroke have been proven to increase the likelihood of recanalization and are under investigation for efficacy for clinical outcome. These methods can be employed alone, in combination, or as adjuncts to intra-arterial thrombolysis. It has been shown that early treatment with aspirin within 48 hours of presumed stroke onset decreases the risk of recurrent stroke, as well as leading to an improved long-term outcome for patients without any major risk of early hemorrhagic complications. Aspirin or clopidogrel loading is usually given for patients with acute stroke who are naive to antiplatelet agents. This presentation outlined the key principles of acute management of ischemic stroke patients. We hope you found it useful. Thank you for your attention. The illustrations are obtained with the kind permission from the following sources.